Hello, everyone. My name is Jackie Berknes-Gartman. I'm a GI and liver pathologist at Johns Hopkins. Today I'm going to be going over slides from several different squamous lesions. So today we're going to go over glycogenic acanthosis, squamous papilloma, epidermoid metaplasia, low and high-grade squamous dysplasia, and squamous cell carcinoma. So starting out, we're going to start with glycogenic acanthosis. This is a benign condition that can present as a raised white plaque in the esophagus. So for this first case, we have two different fragments of tissue. We're going to start with our fragment of essentially normal squamous epithelium. And what I want you to appreciate is our normal architecture or normal maturation. So we have our basal cells at the bottom where we have a very small amount of cytoplasm, a high NC ratio. And as we go towards the surface, we're accumulating more cytoplasm such that we get a lower NC ratio and the cells start to sort of flatten out at the surface. The cytoplasm is somewhere between pink and clear, so we do have a couple of areas of clearing here, but for the most part we have fairly pink cells. So this is an example of normal squamous epithelium for comparison. So we're now going to go over to our lesion. I'm going to flip this around so that the luminal surface is at the top. Go. And the first thing we can appreciate at very low power is that this lesional piece of tissue is a lot thicker than our piece of normal squamous epithelium. So that's the acanthosis part of this. Acanthosis just means that the epithelium is thickened. And the glycogenic part refers to the fact that we have this clear appearance to all of the cells going almost the whole way to the basal layer, and this is due to glycogen accumulation within the cytoplasm. So the term glycogenic acanthosis kind of tells you what this looks like because it is thickened and the cytoplasm is filled with glycogen. So the significance of this finding, one is that we want to be able to explain what the endoscopist saw. So if they're telling us that they saw a white plaque in the esophagus, it's helpful for us to say, okay, that's glycogenic acanthosis. We are able to explain that. Another reason to recognize this is that in some but not all cases, this can be associated with Cowden syndrome. So for instance, if the patient had a history of cancers elsewhere, breast cancer, for instance, maybe we could put this together and suggest a syndromic cause. But in many cases, this is just a benign incidental finding. Moving on to our next lesion, this is an example of a squamous papilloma. So squamous papillomas appear as little bumps in the esophagus. They're benign. And here we can see two sections of this lesion. I'm going to start with this section because it's a little bit better oriented. So the first thing I see is that instead of having a flat surface, I have these finger-like projections at the surface. And if I zoom in, I can see that all of these finger-like projections have these fibrovascular cores that are formed from a combination of connective tissue and blood vessels. And this squamous epithelium is essentially lining all of these cores. So when I go to higher magnification, I actually see very little atypia here. So again, it's a little bit of an unusual arrangement of the cells in that they're all lining these papillae as opposed to just sitting on flat surface. But I can still see maturation from the base here to the surface where we're accumulating cytoplasm. I don't really see any significant atypia. Specifically, I don't see any koilocytes, and these are typically not going to be HPV-associated lesions, except in rare cases of papillomatosis. But usually these are going to be benign and not HPV-related. This is a section of the same lesion, and I want to show this because it shows what it looks like in cross-section. So you could kind of imagine that if you cut through some of these fibrovascular cores, they would look like what we have over here. So again, you imagine this being a finger-like projection, and these are the fibrovascular cores that are in the middle of it. So you can get these two different orientations of the tissue, and both of these represent a squamous papilloma. Going on to another case of squamous papilloma, this one's maybe a little bit more subtle. Again, this would have appeared as a bump in the esophagus or a little nodule. So this piece is a little bit better oriented. We can see that we have a fibrovascular core starting here. We then get a bit of tangential sectioning, and the papillary projection here is cut in cross-section. This piece over here is cut completely in cross-section. And here we can kind of see our papillae here and here, although they're not as well attached to the surface. So in this case, we need to use our imaginations a little bit to kind of piece this together to figure out that this is a squamous papilloma. Again, I see essentially no atypia in here. I don't see any koilocytes, and this is just a benign squamous papilloma. Moving on to epidermoid metaplasia, we're going to start at one end of the tissue to sort of calibrate with fairly normal appearing squamous epithelium. I will say this is a little atypical in that we have an increase in lymphocytes here, so there's some injury going on. But here, again, to sort of calibrate with normal, we have our very thin basal layer and we have our normal maturation towards the surface. So as I go along here, I get to a piece that looks different at low magnification over here. We're going to go to higher magnification. And really the thing that looks different to me is the way the surface looks. We're going to turn this so that the surface is at the top of the slide. So this bottom part looks fairly normal in that we have, again, maturation from the base to the surface, but I'm now accumulating some additional layers that I don't normally see in esophageal squamous mucosa. So this includes a layer of keratin at the surface, and we have a granular cell layer underneath of it. So the granular cell layer is formed by these cells that have these basophilic speckles within the cytoplasm. So this is referred to as epidermoid metaplasia because the esophagus is changing from its normal appearance to an appearance that is more similar to skin, which would have a layer of keratin on the surface as well as a granular cell layer. So the significance of this finding is that epidermoid metaplasia has been associated with subsequent development of squamous dysplasia as well as squamous cell carcinoma. So when I find this, I normally will leave a note saying that while I don't see any dysplasia in this particular sample, this patient is at risk for squamous neoplasia, and I would recommend that they are followed endoscopically. So again, epidermoid metaplasia, we recognize this change at the surface, and we do want to follow these patients. Moving on to squamous dysplasia, the next two sections that I'm going to show are actually from an esophagectomy specimen where the patient had esophageal squamous cell carcinoma. And we're going to be looking at some pieces of the esophagus that were away from the squamous cell carcinoma, and we're going to appreciate the pre-neoplastic changes that we see there. So when we're thinking about squamous dysplasia, before we go to the slide, the things I'm going to be looking for essentially are a change in that normal maturation that I was showing you in the previous cases. So instead of having a very thin organized basal layer and then quickly accumulating more cytoplasm, we're going to get expansion in that basal layer. We can also get some jumbliness. When we're talking about squamous dysplasia, we divide it into low grade and high grade. So low grade squamous dysplasia is going to be confined to the bottom half of the squamous epithelium. And high grade squamous dysplasia typically is going to go into the upper half of the epithelium, but we also can make a diagnosis of high-grade squamous dysplasia if we have really severe atypia at the bases. So we're going to start with an example of low-grade squamous dysplasia. And again, we know that this patient has developed esophageal squamous cell carcinoma elsewhere. All right, so going along here, I start to see some atypia over here where instead of having that very organized, very small, maybe 2-sulfic basal layer, I start to see that I have, sorry, let me just turn this so that we have luminal surface towards the surface. There we go. All right. So we have kind of a thickening of this, of these cells at the bottom that have a very high nuclear to cytoplasmic ratio, meaning not very much cytoplasm. So that's abnormal that this is going higher up. The other thing I see is that these nuclei are a little less well oriented than normal. So I start to see that they're kind of overlapping each other. They're also starting to be different sizes and shapes. So this is an example of low-grade squamous dysplasia. It is limited to maybe the bottom quarter in this case, so it's definitely below half of the epithelium that's involved. Going to continue going along here. I believe there were some other areas that were a little more striking. Okay, so getting over here, we can see essentially the same change. We can see that we have, this is maybe going halfway up at this point. It's sometimes a little bit hard to tell when this is a little bit tangentially sectioned. But again, we can see that our cells with high NC ratio are kind of different. They're kind of different sizes and shapes. They go higher up than we would expect, and they seem to be kind of overlapping each other and very disorganized appearing. So that is our example of low-grade squamous dysplasia. We're now going to go to an example of high-grade squamous dysplasia, and this is actually in the same patient we were just looking at, just elsewhere in their esophagus. And over at this edge of the tissue, we can appreciate high-grade squamous dysplasia. So we see those cells I was pointing out before, where they have a high nuclear to cytoplasmic ratio. They have irregular sizes and shapes of the nuclei, and the nuclei kind of appear to be overlapping each other. And this, I would say, is going almost to the epithelial surface. It's definitely going over halfway up. So I would call this high-grade squamous dysplasia. We're going to continue along here. And again, we can see this is actually getting sort of a swirly look to it. So definitely an abnormal architecture we're getting in addition to all this cytologic atypia. And again, we see that this is going more than halfway up the squamous, the thickness of the squamous surface. And we still continue to have high-grade dysplasia as we go along here. So again, example, and then I will also say, if you look at the slides on your own, this particular slide has high grade. If we want to focus over on this area of the slide, we do have some other areas that I would classify as low grade. For instance, if we go over to this area, I'm not seeing that atypia going halfway up or more. So if I only had this area, I'd be at low grade squamous dysplasia. So this is a good slide to study just to kind of see the spectrum of changes that you can get. And again, we will remember this patient did progress to esophageal squamous cell carcinoma, although that is not on this slide. Going on to another different sample, this is a biopsy specimen, and I want to show you at least high-grade squamous dysplasia here. So we have a fragmented specimen because this is a biopsy, and I want to focus in on some of these fragments here. And again, these are a little bit hard to orient because this is tangentially cut. Let me try to find a better oriented piece here. All right, so this I'm just going to turn so that our luminal surface is towards the top of the screen. And here we can see that we have significant atypia that's going from the base to the surface. So in this case, I actually am accumulating some cytoplasm as I get towards the surface, but I see that I have these extremely atypical nuclei up here that are hyperchromatic. There's very large nuclei, definitely some variation in nuclear size and shape, as well as a mitotic figure that's going higher up. So again, this atypia is going to the upper half. It's pretty severe, so I'd call this high-grade squamous dysplasia. And in this particular case, I actually called this at least high-grade dysplasia, or at least squamous cell carcinoma in situ. We use the term squamous cell carcinoma in situ just to refer to full thickness atypia. And the reason I said that is we have, again, our high-grade squamous dysplasia here, full thickness atypia, but then we have these areas down here that I believe are also neoplastic. So we have these sort of basaloid-looking cells here. By basaloid, I just mean that they have very low NC ratio, or very high, I should say, NC ratio, and they have a very blue appearance at low power. This looks fairly cohesive to me, so I think that this is actually also a component of this squamous lesion, as opposed to these just being all inflammatory cells in here. I'd probably want to do a keratin and a squamous marker like a P40. But when you get these nests down here and you have a bit more trouble telling where the junction is between the epithelium and the underlying stroma, that's when you start to worry, am I missing a early invasive squamous cell carcinoma? And of course, if this was a larger lesion, I would still say, you know, at least in situ, at least squamous cell carcinoma in situ, because we don't know if there's something worse underlying this. So going to our next case, this is an example of a biopsy that I can call on biopsy invasive squamous cell carcinoma. So I want to zoom in on this piece, and we see that we have these very irregularly shaped nests of neoplastic epithelium that are embedded in fibrous stroma. So I can't really think of any way that this could all connect up and be just an in situ lesion. This to me looks invasive given these very irregularly shaped nests. And I can tell that this is squamous as opposed to, for instance, a poorly defined adenocarcinoma, because we have this pink material here, which is keratin pearls. So I would call this, since it does have some keratin formation, a moderately differentiated invasive squamous cell carcinoma. And I now want to move on to a resection specimen. So we were looking at a biopsy before, and I just kind of want to walk you through what this would look like on a resection. So this is an esophagectomy specimen. So what we can see here, I don't see the in situ lesion here, but that's okay. You don't always see it in every section. I'm seeing invasive squamous cell carcinoma here. It looks like this is in the submucosa at this point. So we have our mucosa, lamina propria, muscularis mucosae, so that makes us in the submucosa here. Actually, I'm going to just again orient this for you where we have the luminal surface at the top. There we go. All right, so here we have our invasive squamous cell carcinoma going into the submucosa. As we go farther down here, we can see that the same nests of markedly atypical squamous cells are going into the muscularis propria. Here I can see a nice example of perineural invasion. So this is a nerve in the middle, and we have the squamous cell carcinoma that is wrapping around that. That's perineural invasion. So here it's continuing to crawl through the muscle. All of this pink in here is muscularis propria, and this is all invasive, moderately differentiated squamous cell carcinoma that's crawling through it. And then as I continue down here, I can see that the invasive squamous cell carcinoma is going the whole way through the muscle out into the surrounding soft tissue, which we refer to as adventitia because it's a non-serosalized surface. The other thing we can see is that black ink has been applied to the outside of this specimen. That's something we do during grossing to evaluate the radial margin, so where the surgeon cut around the outside of this specimen. And unfortunately here we do see that we have cauterized tumor going to a margin. So this is a positive margin in the specimen, and that this is very crushed. So if I wanted to confirm that this was in fact cancer, I could do a keratin or a P40, which is a squamous marker. But on the H&E, I do believe that's a positive margin there. All right, moving on to one final interesting case. This is an example of a case that I got as a consult that was fairly challenging. So this was, I believe, a stricture in the esophagus. And the first thing I see here is a spindle cell proliferation. So that always raises a fairly broad differential diagnosis. When we see atypia, for instance, if this was in an ulcer, we could think about some reactive things like bizarre reactive stromal cells that you can get in an ulcer. But this has a bit too much to be something benign. We have hypercellularity. I was able to find some mitotic figures in here, although they're hiding currently. And we have also a decent amount of pleomorphism, meaning that the cells look different one cell to the next. Here's some nice examples of mitotic figures. They kind of look like eyelashes to me. So we have our chromosomes lining up in the middle of the cells, and they're fairly easy to find. Once you find one, you find multiple. And again, here we can see pleomorphism where we have different sizes and shapes of nuclei, with some of them appearing very hyperchromatic. So that makes me concerned that this could be some sort of malignant neoplasm, and that raises a differential diagnosis of sarcomatoid squamous cell carcinoma, or I should say sarcomatoid carcinoma in general. So a epithelial neoplasm that has acquired more of a mesenchymal look to it. We can think about various different types of sarcomas that could arise from different types of soft tissue, such as a leiomyosarcoma arising from smooth muscle, or we can think about a dedifferentiated liposarcoma, for instance, which would come from fat, angiosarcoma, which would come from blood vessels. So there's a fairly broad differential, including many other entities in that sarcoma category. And finally, we always want to think about melanoma, which can look like essentially whatever it wants, particularly if it becomes dedifferentiated. So in this case, I did some stains, and this spindle cell proliferation did turn out to have patchy positive labeling for CK56, which is a type of cytokeratin, as well as patchy labeling for squamous markers P40 and P63. So I ended up interpreting this as a sarcomatoid squamous cell carcinoma. So this is, again, not something I diagnosed on H&E alone. It's something that required some stains. So the other thing that we can do, of course, in these samples is to look at the overlying squamous epithelium. So if I were to find overt squamous dysplasia overlying this, that could point me towards a diagnosis of a sarcomatoid squamous cell carcinoma, but you don't always see that. In this case, I didn't see overt squamous dysplasia at the surface, but what I did see and I believe it was in one of these little pieces over at the bottom. Let's see. Oh, it was this little piece off to the side. All right. So this is starting to look kind of jumbledy to me. So we could start to think, okay, is this an example of squamous dysplasia? But the thing that's interesting is actually the cells that are atypical are kind of spreading upward in a discontinuous fashion in here. So when that happens, where we have malignant appearing cells that are kind of spreading upward in this way, we refer to that as pagetoid spread. We think about that more in adenocarcinomas, but there actually are some descriptions of pagetoid spread in squamous cell carcinoma. And then these did turn out to be positive for squamous markers, and the atypical cells actually labeled a little bit differently from the background squamous epithelium. So I ended up interpreting this as pagetoid spread of squamous cell carcinoma. So it's possible that this person had a conventional squamous cell carcinoma, conventional squamous dysplasia elsewhere that was not biopsied. But the components I was able to see in this biopsy were the invasive squamous, the sarcomatoid squamous cell carcinoma, as well as these really strange pagetoid cells that were spreading upward into the squamous epithelium. So that concludes my talk for today. Thank you for listening.